We've been hearing here at this melanoma meeting a lot about biomarkers, and there is a big need, if you're treating patients with advanced melanoma, to know which of the drugs will work, because these amazing drugs do work, but not always. PD-L1 is such a biomarker. Can you tell me what you've been doing in this particular poster that we've been quickly looking through? What did you do in this study?
So, as you say, the biomarkers is an important need, especially for immunotherapy, because it's a high-cost treatment, and we need to select the patients that can have a benefit. In particular, in the KEYNOTE-002 trial, this is a trial with pembrolizumab in patients who were resistant to ipilimumab treatment. It was retrospectively analyzed the impact of the PD-L1 status in the outcome of patients. And you know that there is a great discussion about the PD-L1 as biomarker. And
it's been found to be quite useful, hasn't it, in other studies?
Yes, there is a great discussion about this. But my feeling in this study, it was found that also the PD-L1 negative patients can have a benefit, and this is consistent with all the other findings.
Right, so tell me, what are the data that came out of this, because you've got a counterintuitive finding in this poster.
Yes, so the data clearly indicated that if a patient is PD-L1 positive, of course the outcome is better, but also in the group of patients PD-L1 negative, we have some benefit for these patients. And for this reason, we cannot avoid the treatment to this group of patients.
Right, now pembrolizumab is in fact targeting PD-1, so the PD-L1 should be something that tells you whether it's going to work or not. How do you explain the fact that both groups of patients did well?
So first of all, it should be clear that the PD-L1 marker is not a molecular marker, but an immunological marker. This means that it's a dynamic marker, so can be upregulated or downregulated at other factors. This is the first point. The second point is that, yes, it's true that the PD-1, PD-L1 pathway works more in the tumor microenvironment, and this is responsible for the higher response rate for this kind of compound with respect to CTLA-4 pathway. But PD-1, PD-L1 pathway can have also an impact during the priming phase, so like CTLA-4. So this means that in the tumor microenvironment, the impact in the ligand from the immunosystem cell and tumor cell is more important. But in priming phase, there is another effect, different, that can have an impact just in terms of overall survival, more the response rate, and this may be the reason because we have benefit also in the negative patient.
Now, in practical medicine then, if you're thinking of using an agent like pembrolizumab or nivolumab targeting PD-1, should you take note of PD-L1 or not?
Not. From my point of view, not. We have some interesting data also from the nivolumab. And in terms of overall survival, the checkmate 066 clearly indicated that the PD-L1 negative patients had a 1-year overall survival rate of 68%. Remember, historically 25.5% of the era pre-new compound, and with ipilimumab we had 44-46%, so 68%. It's close to the 73-75% also target agent, so we cannot avoid to treat these patients with PD-1s.
Right, so targeted agents are working. What are the lessons coming out of this, finally, in summary, would you say, for doctors?
I think that the PD-L1 is not useful for predicting the patients who can respond to PD-1. I think that we need other kind of biomarker, probably the immunoinfiltrate, the immunoprofiling, and you know that from other kind of cancer, like colorectal cancer, and also the data from the KEYNOTE-001 from pembrolizumab show that some signature, and in particular in KEYNOTE-001, the interferon gamma signature can have a role probably more important than PD-L1. I think that we should forget about PD-L1 as a biomarker for predicting outcome. We should go to the way of the immunoprofiling and the gene signature.
And is the hunt for biomarkers promising at the moment, or are we still a bit worried about this?
If we forget about the PD-L1, my answer is yes, because all the data that were shown this year at ASCO and ESMO clearly indicated that the signature, as I said in the profiling, is the best way for selecting patients.